Good afternoon, everyone. So, our next lecture for today is about urologic malignancy. So, among the first topics that we will be discussing is about urinary bladder cancer. So, in 2018, 81,190 men and women will be diagnosed with bladder cancer. So, and 17,240 will die from their disease. So the disease is highly prevalent with over 700,000 patients living with the disease in the United States as of 2016. So men have nearly 3 times the incidence of women. Tobacco use is the most frequent risk factor followed by occupational exposure to various carcinogenic materials such as industrial solvents, aromatic amines. Other risk factors include arsenic, radiation, cyclophosphamide, and chronic exposure to foreign bodies, stones, and catheters, and specific parasites. The most common bladder cancer histology in the United States is urothelial carcinoma, accounting for 90% of the tumors, which tends towards better prognosis as compared to the rarer forms, including squamous cell carcinoma, less than 10%, adenocarcinoma, 1 to 2%, and small cell cancer, less than 1%. Unfortunately, there is no reliable screening test for bladder cancer, although patients felt to be at high risk may undergo urine sampling or for microhematuria or abnormal cytology. Smoking cessation should be advised in all tobacco users as a preventive measure. The most common symptoms at presentation are hematuria, gross or microscopic, and or irritable voiding, urgency, frequency, and dysuria. Office cystoscopy is an effective means to diagnose bladder cancer. Clinical staging is completed with CT or MRI to assess intra-abdominal, nodal, and visceral sites of metastases. The upper tract should be evaluated with CT urography or retrograde pyelography. Chest radiograph provides initial evaluation of the thorax and mediastinum. A bone scan should be obtained if the patient complains of bone pain, has known locally advanced or metastatic disease, or an unexplained elevation in the serum alkaline phosphatase level. The extensiveness of different tumors at their different stages. So the higher the stages, the more deeper it gets. Urinary bladder cancer is especially important in the patient with TIS, TA, or T1 disease, as well as the patient with suspected T2 disease who is being considered for a bladder preservation treatment strategy. Invasion into the lamina propria and certainly the muscular wall demonstrates increased potential for distant metastasis. Muscle invasion is rarely treated completely with TURBT and requires additional therapy for adequate local control. Recurrence rates of non-invasive bladder cancers are high, ranging from 50 to 70%. Adjuvant treatment strategies have thus been adopted after TURBT to reduce these rates. Intravesical chemotherapy used in conjunction with TURBT can reduce the risk of recurrence by 44% to 73% in patients with primary TA and T1 tumors, and by 38 to 65% in patients with recurrent TA, T1, and TIS tumors when compared to TURBT alone. So intravesical immunotherapy using Bacillus calmette-guerin also provides significant reduction and recurrence that is greater than 50% in this population. Despite improved rates of disease-free survival, Standard induction courses of intravesical chemotherapy and immunotherapy do not improve disease-specific survival.
The tissue lining the inside of your bladder is called urothelium or transitional epithelium. The most common type of bladder cancer, called urothelial carcinoma or transitional cell carcinoma, begins in this layer. Here, normal cells change into abnormal cells called cancer cells. Over time, these cells can grow out of control and form a cluster called a tumor. There are two types of urothelial or transitional cell carcinomas based on how they grow. A papillary carcinoma grows in toward the hollow center of the bladder, and a flat carcinoma does not grow in toward the center. Flat tumors are much less common, but they are more likely to spread deeper into the bladder wall. Cancer staging is the process where your doctor figures out if your cancer has spread, and if so, how far. Stage 0 refers to either a papillary carcinoma or flat carcinoma in situ that is only on the surface of the inner lining of your bladder. This means it hasn't spread into your bladder wall. In stage 1, the tumor has grown deeper into the lining, but not into the muscle layer. In stage 2, the tumor has invaded into the muscle layer. In stage 3, the tumor has grown through the muscle layer of your bladder wall and may have spread to nearby organs and lymph nodes. Finally, in stage 4, the tumor has spread to any of the following: the wall of your pelvis or abdomen, or to at least one set of distant lymph nodes, or a distant organ such as your liver or lungs.
There are three types of bladder cancer that begin in different types of cells in the lining of the bladder: transitional cell carcinoma, squamous cell carcinoma, and adenocarcinoma. Transitional cell carcinoma begins in cells in the innermost tissue layer of the bladder. Squamous cell carcinoma begins in the thin, flat cells and may form after long-term infection or irritation. Adenocarcinoma begins in glandular cells that form mucus-like substance and is the rarest type of bladder cancer. It is still not known exactly what causes most bladder cancers. As per the estimates, more than a third of all cases of bladder cancer are caused by smoking. Other risk factors include having a family history of bladder cancer, being exposed to paints, dyes, metals, or petroleum products, having a history of repeated bladder infections, and using urinary catheters for a long time. Signs and symptoms of bladder cancer include blood in the urine, pain during urination, frequent urination, and lower back pain. Tests that examine the urine and bladder are used to diagnose bladder cancer. Physical exam and history makes a necessary part of the workup. Sample of urine is checked for abnormal cells and its content. Medical imaging of the kidneys, ureters, and bladder helps find out the abnormal areas. Cystoscopy has an invaluable role in establishing the diagnosis as it facilitates looking inside the bladder and urethra to check for cancerous areas. It also helps in removing tissue samples, which are microscopically studied to confirm or rule out the presence of cancer. Imaging tests, such as CT scan, MRI, and PET scan, may be used to find out if the bladder cancer has spread and to help with staging. The chance of recovery depends on the stage of the cancer, the type of bladder cancer cells, and the patient's age and general health. If the bladder cancer is superficial, prognosis also depends on the number of tumors, the size of tumors, and whether the cancer has recurred after treatment. Surgical treatment options include transurethral resection with fulguration, radical cystectomy, partial cystectomy, and urinary diversion. Radiation therapy uses high-energy X-rays or other types of radiation to kill cancer cells or keep them from growing. In intravesical chemotherapy, the chemo drug is put directly into the bladder. This type of chemo is used for very early-stage bladder cancers. Systemic chemo can be used before surgery to try to shrink a large tumor or as the main treatment for advanced bladder cancers. As a part of adjuvant therapy, it is used to kill any cancer cells that remain after other treatments. PD-1 inhibitors are a type of immunotherapy used in the treatment of bladder cancer. Early-stage bladder cancer may also be treated with an intravesical immunotherapy called BCG. Regular surveillance of the urinary tract must be done by certain clinical exams and lab tests after a diagnosis of bladder cancer.
So, however, when an induction course of BCG is followed by a series of maintenance doses consisting of weekly BCG given for 3 weeks at 3, 6, 12, 18, 24, 30, and 36 months after induction, disease-free and overall survival can be prolonged. In patients who fail an initial or maintenance course of intravesical therapy, it may be reasonable to try another agent. However, one must consider the risk of progression and not delay definitive treatment. Roughly 15 to 30% of patients presenting with non-muscle invasive tumor will eventually progress to muscle invasion. Radical cystectomy remains the most effective single modality treatment for patients with muscle invasive bladder cancer. Refractory, high-risk, non-muscle invasive disease, and especially lymph node negative disease with reported 10-year recurrence-free survival of organ-confined lymph node negative less than disease between 69 and 87%. Cystectomy is indicated in the treatment of refractory non-muscle invasive bladder cancer or to assert local control for muscle invasive bladder cancer. Effective local control in the pelvis is achieved in 93% of cases with cystectomy. Indications for partial cystectomy are limited and generally apply to isolated tumors or those with diverticulum. Classic teaching suggests that patients with carcinoma in situ or CIS should not be candidates, though the use of intravesical BCG to treat CIS may have broadened this application. For patients with muscle-invasive bladder cancer, neoadjuvant systemic chemotherapy with MVAC or gemcitabine and cisplatin prior to cystectomy offers a survival advantage when compared to radical cystectomy alone. Robotic approaches for cystectomy are increasingly used, but the urinary diversion is still usually performed through an open incision. The benefits of robotic portion are decreased blood loss during the pelvic dissection due to the pneumoperitoneum. However, recent evidence, randomized controlled trials of open versus robot-assisted radical cystectomy did not demonstrate any difference in oncologic efficacy or complication rates. Complications of bladder cancer surgery involve bladder perforation during transurethral resection of the bladder tumor, which require catheter drainage for several days if small, common, or open repair if large, and intraperitoneal, which is rare. Cystectomy and urinary diversion may result in prolonged ill use, bowel obstruction, intestinal anastomotic leak, urine leak, or rectal injury. A urine leak from the urothelial anastomosis is a common cause of ileus, intra-abdominal urinoma, abscess formation, and wound dehiscence. Deep venous thrombosis is common after cystectomy due to the advanced age of most patients. Proximity of the iliac vein to the resection and lymph node dissection, and the presence of malignancy. So the utility of subcutaneous heparin in the perioperative period can minimize the risk of venous thromboembolism. Contemporary series from high-volume centers report readmission rates of 25%, complication rates of 50% to 60%, and perioperative mortality in the first 90 days at 5 to 10%. Urinary diversion can be accomplished using an incontinent or continent abdominal stoma or orthotopic continent reconstruction. The evolution of patient selection and surgical technique has led to improved outcomes for orthotopic diversion, although there are still patients who are better served with an ileal conduit. Motivated patients are considered for orthotopic neobladder diversion if they have a preoperative serum creatinine less than 2 mg per ml, normal preoperative bowel function, a negative urethral margin based on intraoperative frozen section at the time of cystectomy, and an intact sphincter after complete tumor resection. Alternatives to cystectomy include observation, systemic chemotherapy, radiation therapy, or a combination of chemotherapy and radiation. These modalities may be required in patients who are poor surgical risk who refuse surgery, or who are elderly. Bladder preservation using radiation as a definitive therapy may be feasible in selected patients. In this context, trimodality therapy is preceded by aggressive TURBT and offers an improved rate of survival when performed in conjunction with chemotherapy. So up to 42% 5-year disease-specific survival can be achieved in patients with preserved bladders, with the best overall survival outcome in younger patients with lower stage tumors without lymphovascular or nodal involvement. More recently, immunotherapeutic treatments have shown significant promise in the treatment of locally advanced and metastatic bladder cancer. 5 agents have recently been approved for patients who have progressed on or after platinum-based chemotherapy or have progressed within 12 months of neoadjuvant treatment. These agents include PD-L1 inhibitors, atezolizumab, avelumab, durvalumab, and PD-1 inhibitors, nivolumab, and pembrolizumab. Response rates for these agents are 15 to 20%, but may have extended median overall survival as much as 10.3 months when compared to chemotherapy. The next cancer is testicular cancer. So this is the most common cancer in men aged 20 to 40 years old and the second most common cancer in young men aged 15 to 9 years. So metastasis to the testis, usually lymphoma, in the older men are rare. The incidence of testis cancer varies around the world. It contains a heterogeneous group of tumors, of which 95% are germ cell tumors and the rest originate from stromal cells. Germ cell tumors can be classified as either seminomatous or non-seminomatous. Seminoma constitutes more than 50% of all testis cancer. The incidence of bilateral germ cell tumor is approximately 2.5%. There are 4 established risk factors for testis cancer. So, cryptorchidism, undescended testis, family history of testis cancer, personal history of testicular cancer, and intratubular germ cell neoplasia. Most patients present with testicular pain or testicular mass. Respiratory symptoms, back pain, weight loss, or gynecomastia may indicate metastatic disease in 10 to 20%. A testicular mass is considered malignant till proven otherwise. Similarly, retroperitoneal lymphadenopathy in young men should be considered metastatic testicular cancer. Standard initial workup includes scrotal ultrasound and serum tumor markers, alpha-fetoprotein, quantitative human chorionic gonadotrophin, and lactate dehydrogenase. Most consider percutaneous biopsy contraindicated due to the rare but historical risk of disturbing the natural lymphatic drainage to the retroperitoneum and possible seeding to the scrotum. Radical inguinal orchiectomy is the gold standard treatment for excision of the primary tumor. Partial orchiectomy through an inguinal approach may be considered in some cases, including a suspected diagnosis of lymphoma. Chest and abdominal axial imaging are the main staging tools. Testicular cancer has very predictable pattern of spread. Right testicular cancer tends to metastasize to the interaortocaval lymph node, followed by paracaval and para-aortic lymph nodes. Left side, the testicular cancer rarely crosses to the paracaval lymph nodes. Clinical TNM staging includes local stage, distant metastasis, and tumor markers. Depending on the stage and histology of the primary tumor, multiple treatment options are available. These include active surveillance, retroperitoneal lymph node dissection, and adjuvant chemotherapy or radiation therapy. Active surveillance for localized disease follows a tight schedule of physical exams, tumor markers, and imaging studies. The cancer recurs in 20 to 30% of patients on active surveillance. The presence of embryonal carcinoma and vascular invasion seem to be interrelated predictors of recurrence. Recurrence usually occurs within the first 2 years and in the retroperitoneum. Pure seminoma is radiosensitive Stage 1, 2A, and 2B, disease can be treated with external beam radiation therapy to the retroperitoneal nodes. Alternatively, a single dose of carboplatin for stage 1 seminoma was found to be just as effective as radiation therapy. More advanced seminoma is treated with platinum-based systemic chemotherapy. Stages 1 to 2A non-seminomatous testis cancer is potentially cured with RPLND or chemotherapy. Persistently high tumor markers are radical orchiectomy or high-stage metastatic germ cell tumors warrant systemic chemotherapy due to the high rates of teratoma or viable germ cell tumor. Post-chemotherapy, bulky masses are resected by RPLND or other surgical procedures. The overall survival rate of localized disease is outstanding, 99% at 5 years. Patients with more advanced distant metastasis disease, stage 3, have 75% survival rates. The overall prognosis is generally better for seminomatous than non-seminomatous germ cell tumors. Surgical considerations in testicular cancer. Radical orchiectomy is done through an inguinal incision extending from an external inguinal ring to the internal inguinal ring. The spermatic cord is ligated at the internal ring and a long silk sutures for easier identification during a future RPLND. Integrity of the scrotal skin during orchiectomy is important. Complications of radical orchiectomy include scrotal hematoma, chronic pain, and hernia. So this is how you do it. So you incise on the inguinal area, you look for the spermatic cord, and then you ligate it as high as you can. And here is a template for modified retroperitoneal lymph node dissection, wherein you remove all the lymph nodes in the landing sites of the tumor. For RPLND, a midline incision is usually made from the xiphoid process to the pubic symphysis. All of the lymphatic tissue is removed from the targeted areas using the classical split and roll technique, and all lumbar vessels are tied. Post-ganglionic sympathetic nerve sparing is possible in most cases for preservation of ejaculatory function. Robotic-assisted RPLND is growing with faster recovery time and similar short-term oncologic results. Complications after RPLND include bowel obstruction, excessive bleeding, chylous ascites, and ejaculatory dysfunction.
If you are a man, you have a pair of egg-shaped glands called testicles enclosed in your scrotum, which is a pouch that hangs behind your penis. Your testicles produce sperm cells and make the hormone testosterone. Inside each testicle are coiled tubes called seminiferous tubules, where your body creates immature sperm cells, also known as germ cells or spermatogonia. Through a series of stages called spermatogenesis, spermatogonia develop into mature sperm. Testicular cancer is a disease of abnormal cell growth in one or both of your testicles. It usually begins in your germ cells, where genetic damage or changes called mutations cause the cells to grow uncontrollably. The cancerous germ cells clump together to form a tumor which continues to grow. In most cases, these mutations occur in your germ cells and are called germ cell tumors. Doctors classify germ cell tumors as non-seminoma or seminoma, or based on the appearance of the cells under a microscope. Non-seminomatous tumors are usually more aggressive. They grow and spread quickly, while seminomatous tumors tend to progress at a slower rate. Symptoms of testicular cancer may include a painless mass on your testicle, or testicular pain or swelling. If you have testicular cancer, your doctor may recommend surgery, chemotherapy, radiation therapy, or a combination of treatments based on the type and stage of the tumor. Your treatment will begin with the removal of the cancerous testicle through a radical inguinal orchiectomy. For this procedure, your surgeon will make an incision in your lower abdomen. Then your surgeon will remove your testicle from your scrotum. Your surgeon will close the incision with sutures or surgical staples. Next, your pathologist will analyze the testicle to determine which type of cancer you have and to plan further treatment. If you have enlarged abdominal lymph nodes, or if samples of your blood indicate the presence of cancer following your orchiectomy surgery, your doctor may recommend chemotherapy. Chemotherapy uses drugs to stop cancer from progressing by killing the cancer cells that may have spread through your lymph nodes to other parts of your body. If your tumor contains the more aggressive non-seminoma cells, your surgeon may perform a retroperitoneal lymph node dissection after you receive chemotherapy. During this procedure, your surgeon will insert laparoscopic tools through small incisions in your abdomen. Then your surgeon will remove your abdominal lymph nodes, including any cancer cells that may have spread to them. If you have a seminomatous tumor, your doctor may recommend radiation therapy or radiotherapy, which uses high-energy X-rays to kill cancer cells only in the treatment area. During this procedure, your doctor will direct external beam radiation therapy at your retroperitoneal abdominal lymph nodes. The radiation beam will kill any cancer cells that may have spread there.
The next cancer would be renal cancer. It still remains primarily a surgical disease and classically does not respond to conventional chemotherapy or radiation. Most patients diagnosed with RCC in the modern era typically present with an incidentally discovered renal mass on abdominal radiographic imaging. So differential diagnosis of a renal mass includes malignant tumors, RCC, urothelial carcinoma, sarcomas, lymphomas, metastases. Benign tumors, cysts, angiomyolipoma, oncocytoma, and inflammatory lesions such as abscesses, xanthogrellium-lomatous pyelonephritis, tuberculosis are also considered. So, renal CT imaging with intravenous contrast remains the single most important radiographic test to delineate the nature of the mass. So in general, any solid renal mass that enhances by more than 15 Hounsfield units is an RCC until proven otherwise. However, even if there is contrast enhancements on eggshell imaging, approximately 15 to 30% of solid renal masses are benign on final surgical pathology. Renal tumor biopsy can help distinguish between malignant or benign tumors, but this has not been widely adopted by the urological community. And despite series showing their high diagnostic yield, concordance with surgical pathology, and safety, biopsy remains particularly useful in patients considering surveillance or thermoablative therapy or in patients with suspicion of metastasis or lymphoma. Major recognized risk factors for RCC include smoking, obesity, and hypertension. Although most RCCs are discovered incidentally, some patients present with signs or symptoms which may result in local tumor growth. For example, flank pain, hematuria, and perirenal hematoma. Paraneoplastic syndromes such as hypertension, weight loss, hypercalcemia, polycythemia, anemia, abnormal liver function tests, or metastatic disease, RCC or metastatic disease. RCC metastasizes primarily to the lungs, lymph nodes, bone, liver, adrenal glands, and the brain. Familial RCC subtypes with classical clinical manifestation are also well described. The von Hippel-Lindau disease, occurring as a result of mutation in the tumor suppressor gene VHL 3p25 to 26 commonly manifests itself with clear cell renal cell carcinoma, pheochromocytomas, retinal angiomas, central nervous system hemangioblastomas, pancreatic cysts, and other tumors. Other familiar syndromes include hereditary papillary RCC, papillary type 1 RCC, familial leiomyomatosis, papillary type 2 RCC, and Birt-Hogg-Dubé syndrome, chromophobe RCC, hybrid oncocytomic tumors, and oncocytoma. Familial RCC syndrome should be suspected in younger patients and patients with multicentric or bilateral tumors. Clear cell RCC is the most common subtype, accounting for 70 to 80% of all RCCs. Papillary RCC occurs 10 to 15%, type 1 being associated with better prognosis and type 2 a worse prognosis. Other subtypes include chromophobe RCC, collecting duct carcinoma, and unclassified type. RCC may locally progress and cause invasion of the renal capsule and perirenal fat or the collecting system. RCC may also directly progress into the venous system in the form of tumor thrombus, and that can extend into the IVC and into the right atrium. Staging is the single most important prognostic factor for RCC. Studies demonstrate at 70 to 90% 5-year survival rate for organ-confined disease, compared to 0 to 10% for patients with systemic metastasis, stage 4. Other important prognostic factors include histological subtype, tumor size, lymph node involvement, and site of metastasis. So management options for renal masses less than 4 cm includes active surveillance, thermoablative techniques, or surgical excision. Percutaneous or laparoscopic thermoablative techniques, cryoablation, radiofrequency ablation, high-intensity focused ultrasound have been used to treat small renal masses, but they are associated with an increased risk of local recurrence. Partial nephrectomy is the most appropriate for patients with small tumors, solitary kidney, bilateral tumors, or familial RCC. Some tumors may not be amenable to ablative therapies or partial nephrectomy, in which case radical nephrectomy would be employed. Radical nephrectomy involves removal of the entire kidney with dissection external to the derotas fascia. The colon is retracted medially after incising the white line of thought, followed by meticulous hilar dissection with ligation of the renal artery and vein. The adrenal gland is usually spared unless the tumor involves the gland or is immediately adjacent to it. Lymphadenectomy remains controversial, and it is usually performed in patients with adenopathy on preoperative imaging or in patients with palpable lymph nodes intraoperatively. In partial nephrectomy, renal artery clamping is often performed to minimize blood loss while the tumor is excised. The goal is to remove the tumor with negative surgical margins while minimizing warm ischemia time to preserve as many functional nephrons as possible. With increasing experience, partial nephrectomy is now also performed on much more complex renal masses, including completely endophytic, central, and hilar tumors. Very large tumors or tumors with vena cava thrombi can be removed robotically in experienced hands, but most are still removed using an open approach. In minimally invasive surgery, both partial and radical nephrectomy can be done via either a transperitoneal or retroperitoneal approach. In open cases, a subcostal flank approach provides direct access to the retroperitoneum and is preferred for lower pole exposure, but it can limit access to the hilum, and particularly with large renal masses. The anterior subcostal approach is preferred for large renal masses. Bilateral anterior subcostal incisions, chevron incision, provides excellent vascular exposure. For example, in IVC, inferior vena cava thrombectomy, and bilateral tumors. Midline incisions are usually reserved for renal trauma and for reconstructive procedures. Less commonly performed, The thoracoabdominal approach involves access usually above the 10th rib and is used for large upper pole or adrenal masses, inferior vena cava thrombectomy, or tumors involving adjacent structures. Complications include injury to the adjacent organs and for partial nephrectomy, pseudoaneurysm, arteriovenous fistula formation, and delayed urinary leak.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread.
The next cancer is prostate cancer. Screening for prostate cancer with detailed history, digital rectal examination, and serum PSA tests have changed the natural history of the disease. Since the introduction of prostate cancer screening in the mid-1980s, the incidence of metastatic prostate cancer has decreased by half. Currently, 99% of newly diagnosed patients will survive more than 10 years, while early screening for African American patients or patients with a family history of prostate cancer is widely accepted. Screening for all men is more controversial, despite data from large randomized clinical trials showing a decrease in mortality after prostate cancer screening. The U.S. Preventive Services Task Force recommend against the routine use of prostate cancer screening. Its recommendation was based on the harm and toxicity of overtreatment of non-lethal disease. The American Urological Association subsequently recommended informed and shared decision-making and screening for high-risk disease for men between ages 55 and 69 with a life expectancy of more than 10 years. If the digital rectal examination is abnormal or if the PSA level is above expected for patients, age and size of the prostate biopsy is usually performed. Newer tests such as the 4K score, prostate health index, and PSA3 are sometimes used to inform the decision to proceed with biopsy. Recently, MRI fusion transrectal ultrasound guided biopsy improved the accuracy of prostate biopsy. Since most patients survive in the disease, risk stratification systems are routinely utilized to guide staging and treatment. Clinical TNM stage, serum PSA levels, and the Gleason score are utilized in the clinical practice. So more recently, genetic testing on biopsy specimen was included in the national guidelines. Historically, the Gleason scoring system included a primary and a secondary score based on the most common and the second most common histologic patterns. So grades ranges from 1 for the most differentiated to 5 for the least differentiated. So the grades are added to create a resultant Gleason score. However, since no patients are assigned a score of less than 5 or more anymore, the grading system has been modified to the scale from 1 to 5. Grade 1 includes Gleason score of 3 plus 3 equals 6 or less. Grade 2 for 3 plus 4. Grade 3 for 4 plus 3. Grade 4 for 4 plus 4. And grade 5 for Gleason score of 9 or 10. Imaging studies like CT and bone scans are used to rule out metastatic disease in high-risk patients. The two most common sites of metastatic disease are pelvic, retroperitoneal lymph nodes, and bony structures. Modern CT PET scans have limited role at this point. Treatment for localized prostate cancer is guided by cancer aggressiveness and patients' preferences. Active surveillance is recommended for patients with low-risk disease, grade 1 to 2, early-stage disease, clinical T1C, and small volume disease as determined by biopsy. Large prospective controls, cohorts, and randomized clinical trials have established the safety of this approach. The risk of progression to metastatic disease with close follow-up and repeat prostate biopsy is less than 2% in over 12 years. Radical prostatectomy and pelvic lymph node dissection, image-modulated radiation therapy, and brachytherapy are the standard of care for curative treatments. All provide equal cancer-specific survival for low and intermediate risk cancers. For higher risk prostate cancer patients, both surgery and IMRT with androgen deprivation therapy provide an excellent cancer control. Cryotherapy or high-intensity focused ultrasound or HIFU and focal therapy are emerging options that may be acceptable for some patients with low-risk disease. So level 1 evidence has established the role of adjuvant radiation therapy after radical prostatectomy for patients with positive surgical margins. Extracapsular extension and high-grade disease after definitive treatment of localized prostate cancer, rising PSA is an extremely reliable indicator of recurrence or progression. So, however, it may take over 10 years for metastasis to appear on imaging studies. Once prostate cancer metastasizes, it is no longer curable. Medications that lower serum testosterone or androgen receptor blockers are able to control the disease, often for years. In addition, chemotherapy, immunotherapy, and radioisotope therapy at different stages of the disease increase the life expectancy of the patients or improve the quality of life. The cancer inevitability becomes resistant to these treatments. Nevertheless, patients with incurable prostate cancer can live many years and a large number die of causes other than prostate cancer. So over the past few years, we have witnessed major developments in the management of metastatic castrate-resistant prostate cancer or mCRPC. New agents that interrupt androgen synthesis and new modulators of androgen receptors and salutamides have significantly improved the life expectancy of patients with both androgen-sensitive and resistant metastatic prostate cancer. Similar innovations in immunotherapy and chemotherapy delivery have advanced the management of advanced prostate cancer. Open radical retropubic prostatectomy is done through a lower midline incision from below the umbilicus to the pubic symphysis. After entering the space of retuse, the external iliac obturator and internal iliac nodes are removed. The cavernosal nerves located on the posterolateral surface of the prostate capsule are usually spared on the sides, with low risk of extracapsular extension of the disease. Then the prostate is removed in a retrograde fashion, and the uretrovesical anastomosis is completed in an interrupted fashion. Robotic radical prostatectomy using the Da Vinci robotic surgical system is now the common technique. Over 90% of all patients in the United States for surgical treatment of localized prostate cancer is being done robotically. Robotic surgery has lower blood loss and faster convalescence, less bladder neck contracture, and lower early postoperative complications. Some data show a faster return of continence and lower rates of erectile dysfunction. So here is a video about a robotic radical prostatectomy. The most common postoperative complications include infection, urine leaks, ill use, lymphocele, and very rarely rectal or urothelial injury. To minimize the impact of these side effects, researchers have used different ablative techniques to obliterate the areas of significant cancer by avoiding the need for whole gland radiation or removal. These focal ablative therapies aim to balance the long-term impact on quality of life with survival. Laser, high-focused ultrasound, cryotherapy, and photodynamic ablations have showed similar results in early studies.
The prostate is a gland in men that makes part of the fluid in semen. It's found just under the bladder, in front of the last part of the large intestine, called the rectum. The prostate wraps around part of the urethra, which is the tube that passes urine and semen out of the body. Most prostate cancer starts in tiny sacs within the gland that make prostatic fluid. Here, cancer cells form from gland cells that line the sacs. Over time, the cancer cells can multiply and form a malignant or cancerous tumor. However, most prostate cancer grows more slowly than other types of cancer. An important risk for prostate cancer is age. Prostate cancer is more common in men over the age of 65. Race is another risk factor. Prostate cancer is more common in African American men than in any other race. The risk is also higher in men whose relatives, such as a father or brother, have a history of prostate cancer. There are usually no symptoms in early prostate cancer. However, as the tumor enlarges the prostate, you may have the following symptoms: difficulty starting urination, weak, interrupted, or painful urination, needing to urinate frequently, especially at night, painful ejaculation, problems getting an erection, blood in urine or semen, and pain or stiffness in the lower back, hips, or pelvis. Note that these symptoms may be caused by prostate enlargement that is not cancer. If you have prostate cancer, your doctor will need to determine the grade and the stage or progression of the disease. Each grade is based on how normal the prostate tissue looks under a microscope. The grading system for prostate cancer is called the Gleason grading system. In this system, samples of two main areas of the tumor will each be given a grade from 1 to 5. The grades will be added together to give the cancer a Gleason score between 2 and 10. The higher the Gleason score, the more likely the cancer is to grow and spread to other areas. Each stage for prostate cancer is based on the amount of cancer you have and where it's found. The stages are numbered from 1 to 4. In stage 1, the tumor has not spread outside the prostate. In stage 2, the cancer is more advanced but is still only in the prostate. In stage 3, the cancer has spread just beyond the outer layer of the prostate. And in stage 4, the cancer has spread into nearby tissues as well as more distant areas of the body.
Most early-stage prostate cancer can be treated successfully. In some cases, the tumor will grow so slowly it can be monitored with active surveillance, which can delay or avoid other treatments. Other types of prostate cancer treatment include surgery, radiation therapy, hormone therapy, which is referred to as androgen deprivation therapy or ADT, and chemotherapy. The treatment you and your healthcare team choose will depend on the stage of your cancer and your overall health. Some of these treatments may cause side effects that can affect your daily life. That's why it is important to think about your lifestyle when you are looking at the different treatments for your disease. At your next appointment with your healthcare team, make sure you tell them what is important to you as you consider the different kinds of treatment. For example, sexual intimacy with your partner may be important to you, so you may decide on a treatment that will have fewer sexual side effects. Don't be afraid to ask your healthcare team for advice. It's also common to get a second opinion if you need help choosing the right treatment for you. Understanding your diagnosis and working with your healthcare team will help you take control of your life with prostate cancer.
The last but not the least cancer that I will be discussing is urethral carcinoma. It is a relatively rare disease, the true incidence of which is unknown. It accounts for less than 1% of genitourinary cancer. In fact, I only encountered, I think, one case during my whole urologic practice. It is a disease of the older adult. Risk factors include chronic inflammation from sexually transmitted diseases, human papilloma virus 16 and 18 in squamous cell carcinoma, chronic urethral stricture, and indwelling catheterization. Furthermore, urethral diverticulum and recurrent urinary tract infection increase the risk for women. The majority of patients presents with irritative, obstructive voiding symptoms, bleeding, or a palpable mass. Urothelial carcinoma is the most common histology. 29% of women have adenocarcinoma. And both genders can have squamous cell carcinoma. Untreated or refractory urethral cancer typically metastasizes through the lymphatic channels to the inguinal and pelvic lymph nodes and hematologically to distant organs. Cystoscopic biopsy establishes the diagnosis. An MRI of the pelvis is extremely helpful for defining local extension of the disease, while CT scans of the chest, abdomen, and pelvis identify metastatic disease. The 5-year overall survival rates for distant urethral tumors is significantly better than for proximal cancers, 68% versus 40% respectively. The median 5-year cancer-specific survival is approximately 46%, so very poor. Prognosis is dictated by patient's age, race, clinical stage, and location of the tumor. So if visible, local endoscopic resection for low-volume, low-stage disease is preferable. Adjuvant intravesical installation of BCG should be considered for patients with proximal non-invasive disease. Due to the paucity of the robust data, management of locally advanced disease is more challenging. Either radical cystectomy or radiations are acceptable options. Unfortunately, local recurrence rates are high after aggressive monotherapy. More recent data support the use of multimodal therapy. A small series of combinations of perioperative chemotherapy, surgery, and radiation indicate the best cancer control. That's it for my lecture. Have a nice day.